highly complex surgery used to treat pancreatic cancer and other conditions affecting the pancreas, bile duct, or duodenum. Below is a step-by-step detailed description of the surgical process, focusing on the technical aspects and precision required. Preoperative preparation. Before surgery, the patient undergoes detailed evaluations. Imaging studies, CT, MRI, or endoscopic ultrasound, to confirm resectability and exclude metastasis. Blood work, including liver function tests and coagulation profiles. Nutritional assessment and optimization. Clearance for anesthesia and surgical fitness. Surgical steps. 1. Incision and exploratory laparotomy. A midline incision is made from just below the xiphoid process to the umbilicus, or a bilateral subcostal chevron incision is used to access the abdominal cavity. The peritoneal cavity is inspected for metastases, liver, peritoneum, and involvement of major vascular structures, e.g., superior mesenteric artery or vein, portal vein, hepatic artery. If unresectable disease is identified, the procedure is aborted and palliative care options are considered. 2. Mobilization of the duodenum and pancreas. The Kocher maneuver is performed to mobilize the duodenum. The peritoneum along the right lateral border of the duodenum is incised. The duodenum and head of the pancreas are reflected medially, exposing the retroperitoneal structures, including the inferior vena cava, IVC, and aorta. The hepatic flexure of the colon may be mobilized to improve access. The surgeon carefully dissects the superior mesenteric vessels to assess tumor involvement and ensure resectability. Vascular dissection and control. Portal vein and superior mesenteric vein, SMV. The SMV is identified and careful dissection is performed to separate it from the uncinate process of the pancreas. In cases where the tumor encases the vein, vascular resection and reconstruction may be performed. Superior mesenteric artery, SMA. Dissection along the SMA ensures the tumor does not invade this critical structure. This is a key step to determine resectability. Celiac axis and hepatic artery. The gastroduodenal artery is ligated, and the hepatic artery is preserved for blood flow to the liver. Division of structures. Stomach or pylorus. If the classic Whipple is performed, the distal stomach is transected 2 to 4 centimeters proximal to the pylorus. In a pylorus preserving procedure, the pylorus is spared and only the proximal duodenum is divided. Pancreas. The neck of the pancreas is transected with sharp dissection or electrocautery. Care is taken to identify and ligate the pancreatic duct to minimize leakage. Common bile duct. The bile duct is transected above the level of the cystic duct insertion to remove the distal bile duct along with the head of the pancreas. Jejunum. The proximal jejunum is divided approximately 15 to 20 centimeters distal to the ligament of Treitz, ensuring a tension-free reconstruction. OSH5. Resection of the specimen. The head of the pancreas, distal stomach, if applicable, entire duodenum, proximal jejunum, gallbladder, and distal bile duct are removed en bloc. The surgical field is examined for hemostasis, ensuring no active bleeding from small vessels. 6. Reconstruction phase. Reconstruction is performed to restore continuity of the gastrointestinal tract. 1. Pancreaticogenostomy. The remnant pancreas is mobilized and the pancreatic duct is identified. The duct is anastomosed to the jejunum using either a duct to mucosa anastomosis with fine absorbable sutures, an invagination technique where the pancreatic stump is invaginated into the jejunal loop. A stent may be placed in the pancreatic duct to prevent stricture or leakage. 2. Hepaticojejunostomy. The transected hepatic duct is anastomosed to the jejunum in an end-to-side fashion. A separate jejunal loop is created to prevent reflux of intestinal contents into the biliary tree. 3. Gastrojejunostomy, or duodenojejunostomy. If the stomach was divided, a gastrojejunostomy is performed by connecting the stomach to the jejunum. In pylorus-preserving cases, the duodenum is anastomosed to the jejunum. 4. Reconstruction configuration. A Roux-en-Y or loop reconstruction may be used to connect the jejunum to the biliary and pancreatic systems. 7. Placement of drains. Surgical drains are placed near the pancreaticojejunostomy and hepaticojejunostomy to monitor for pancreatic or biliary leaks. The abdomen is irrigated with sterile saline to remove debris and blood clots. 8. Closure. The abdominal incision is closed in layers, ensuring secure approximation of the fascia and skin. Sutures or staples are used based on surgeon preference. Postoperative care and monitoring. The patient is transferred to the ICU for intensive monitoring of hemodynamic stability, early signs of complications such as bleeding, infection, pancreatic fistula, or delayed gastric emptying, electrolyte balance and nutritional support, often via enteral feeding or total parenteral nutrition, TPN. Complications specific to surgical steps. 1. During mobilization, injury to major vessels like the IVC or SMA. 2. During resection, incomplete tumor removal or vascular injury. 3. During reconstruction, anastomotic leakage, particularly at the pancreatic ojejunostomy. The Whipple procedure remains a technically demanding surgery, requiring meticulous planning, skilled execution, and comprehensive postoperative care to maximize outcomes.